Dear students, in this class we will be discussing the pharmacology of uh, anti-tubercular drugs. By the end of this lecture, you will be able to describe the sign and symptom of tuberculosis. We will just have a brief introduction about that, and then we will discuss the classification and mechanism of actions, the pharmacokinetic profiles, compare and contrast the adverse events profile for anti-tubercular drugs and therapeutic indication for these drugs. This is a scanning electron micrograph of the Mycobacterium tuberculosis. Normally, it remains in the dormant condition within the body, in the lungs, deep in the lungs. Whenever there is a decrease or it find an opportunity when the immune system depressed down, then in 5 to 10% of the people it can cause this tuberculosis, active tuberculosis. That's why it is very difficult to treat one against a dormant, and it has a waxy shield that restrict the drug to penetrate this mycobacterium. That's why we cannot treat it with a single drug, and we need a combination of drugs in order to kill this bacterium. The main symptoms of pulmonary tuberculosis included chest pain, coughing of blood, and productive and prolonged coughing. Productive when there is a sputum in the cough, that is called productive cough. A skin, night sweats, and pallor. Central effect, it has appetite loss and fatigue. So these are the signs and symptoms mainly associated with these lungs. So it can affect the lungs mainly. The treatment strategy for treating this Mycobacterium tuberculosis is a big problem. Basically, one of the problem with this Mycobacterium is that it has a lipid-rich cell wall, so it's make it difficult for the drugs to penetrate into this bacterium. And another is the slow growth rate of this Mycobacterium. So that's why this bacterium needs to be treated for a long time, at least for 6 months, and then it can go up to 1 year or even up to 2 years in some cases. So that's why we have to use a combination of drug in order to decrease the resistance and the side effects of these drugs. That's why we have a first-line drug which are considered to be as the most effective and have the lowest toxicity. These include isoniazid, rifampicin, pyrazimide, and ethambutol. So these are the 4 drugs in the first-line treatment. If the patient evolve resistance to any of these first-line drugs, then we can go for second-line of drug which are less effective and more toxic. Normally, these second-class drugs include aminoglycosides, capromycin, ciprofloxacins, or other antibiotics that we have discussed in the antibiotic sections. So the standard treatment for Mycobacterium tuberculosis, this is the short-term period, which include 6 months. So this has to be initiated with all the 4 drugs: isoniazid, rifampicin, pyrazimide, and ethambutol. So the 4 of them has to be continued for 2 months, and after that only isoniazid and rifampicin can be continued for 6 months. So after that, the patient has to be checked again for the presence of Mycobacterium tuberculosis. If the test is negative, then it's fine. But if the test is positive, then it can continue for 9 months, up to a year, or in some cases, it can go up to 2 years. So this is the standard or short course treatment for Mycobacterium tuberculosis: isoniazid, rifampicin, pyrazimide, and ethambutol for 2 months, and then the 2 isoniazid and rifampicin has to be continued for another 4 months. So collectively 6 months is the standard short treatment course. The patient is considered cured at 6 months, although there is still a relapse rate of 2 to 3%. If the organism is known to be fully sensitive, then the treatment is with the isoniazid, rifampicins, and pyrazinamide. So if the mycobacterium is fully sensitive, then you can continue with this 3 drug for the first 2 months and then continue for these 2 drug for the other 6 months. So in order to cope up with this mycobacterium, we have to target it from all of its site, like this isoniazid, ethambutol. They are affecting this different steps in the formation of cell wall. Pyrazinamide is affecting the cell membrane, and also it is disrupting the energy system, while the rifampicin is inhibiting the RNA synthesis or replication. So all these drugs have synergistic action, and they have to be continued for at least 2 months, and then we can continue for next 4 months with isoniazid and rifampicin. So what's the function of isoniazid? We will discuss it in details. Isoniazid, also called as INH, considered the first the drug of choice for the chemotherapy of tuberculosis. It is bacteriostatic for the resting bacilli and bactericidal for the growing bacilli. So it has both the actions, and it's the most potent of all these anti-tubercular drugs. A mechanism of action: it is a prodrug and must be activated through bacterial enzymes. So it is a prodrug, like we have discussed previously. It has to be converted to its active form by the bacterial enzyme. So the primary action seems to inhibit the biosynthesis of mycolic acid, which is part of the cell wall structure that we have discussed in there. That is, the mycolic acid is the main component of the mycobacterial cell wall, and this isoniazid is inhibiting the synthesis of this mycolic acid. Now resistance, as we are using these drugs for a longer time, so there is a chance that these drugs can, or these mycobacterium can evolve resistance. So the mechanism of resistance is related to the failure of the drug to penetrate or taken up by the microorganism by the active transport system. So one of the mechanisms that these mycobacterium evolve is to inhibit the drug to be taken up by the bacterium. Because the treatment is for up to 2 years, in some cases it can go, so these drugs can evolve resistance. Another mechanism of resistance is the mutation is the catalase peroxidase enzyme, because this catalase peroxidase enzyme is responsible for the conversion of this inactive isoniazid into its active form. So if the bacteria mutate this catalase peroxidase enzyme or inhibit the formation of or synthesis of these enzymes, then this drug become inactive. So it will not convert it to its active form, and then it will not be effective anymore for these mycobacteria. Absorption: pharmacokinetics, INH is rapidly absorbed either through oral or parenteral route. So it has a good bioavailability after oral absorption. It diffuses readily into all body fluids, does not bind to the plasma protein. So most of the drug remain in the free and active form within the plasma. In the cerebrospinal fluid, the concentration is about 20%. So it can go into the cerebrospinal fluid. Excretion is mainly through the urine, through the kidney, so 75 to 95% of the dose excreted in the urine in 24 hours. One of the main issue regarding its metabolism, that some people are slow acetylator while some are fast acetylator, and this drug has to be acetylated during metabolism. So the main excretory product is acetyl isoniazid. This is the result of enzymatic acetylation. So very important in terms of metabolism, because fast acetylator will, some peoples are fast acetylator, so it will metabolize this drug rapidly, and it will have short half-life in fast acetylator, but in slow acetylator it will have longer half-life. And this acetyl isoniazid, the byproduct of this isoniazid, it is very toxic as well. So fast acetylator will have more acetyl isoniazid and can have more side effect as compared to the slow acetylator. So as we have discussed, after metabolism, it is converted to a byproduct acetyl isoniazid, which is toxic, especially it is hepatotoxic. So and it has to be used for around 6 months at least, and maybe up to go up to 9 or 1 year. So that buildup of this acetyl isoniazid can lead to hepatitis. Peripheral nephropathy, it can also causes the deficiency of vitamin B6. So long-term use of these drugs can lead to peripheral neuropathy. Isoniazid inhibition causes inhibition of the hepatic enzyme, and that's why it can lead to the decrease in the metabolism of certain drugs, especially the drugs which have narrow therapeutic index. So those drugs which have narrow therapeutic index, and if this isoniazid decreases their metabolism, so it will lead to higher bioavailability of these drugs, and they can lead to toxicity. So competition between isoniazid and phenytoin, this is the anticonvulsant drug which have a very narrow therapeutic index and have a lot of side effects. So if you are using if a patient is using this phenytoin along with this isoniazid, it can cause the side effect produced by the phenytoin. So isoniazid inhibit the metabolism of phenytoin, thus increasing phenytoin plasma concentration. It decreasing the metabolism of phenytoin, and that will lead to increased plasma concentration of the phenytoin. Rifampicin is the second class in this anti-tubercular drug, and it inhibits the DNA-dependent RNA polymerase of this mycobacterium, inhibiting the transcription and division of these mycobacterium tuberculosis. Resistance due to alteration of the target DNA-dependent RNA polymerase. So when these drugs are used for a longer time, these mycobacterium can mutate the RNA DNA-dependent RNA polymerase, and that will lead to the inactivation of these drugs. The microorganism can change the structure of the enzyme, so the drug no longer bind to its site and will become ineffective. Pharmacokinetics: the peak plasma reached 2 to 4 hours after oral doses, can be used rapidly eliminated in the bile and reabsorbed enterohepatically. So this is enterohepatic circulation. It goes into the liver, and then it's secreted back, and then it goes absorbed back into the liver. Normally, this drug is well tolerated and do not have that most of the side effect associated with isoniazid or other drugs. It can cause some GIT reactions like nausea, vomiting, mild abdominal pain. Hepatic reactions are rare, but it can be produced in children, in pregnant women, or elderly people, or those who are using alcohol, because alcohol in itself is hepatotoxic. So that will really result in a minor elevation of serum transaminase enzymes, which are the diagnostic for the liver function. Allergic reactions, fever, and rash are the mild side effects associated with this drug. Pyrazine exerts its bacterial action. This mechanism of action is not clearly understood yet. It is given orally, and it can impair the liver functions, and it can decrease the renal urate elimination. That way it will lead to hyperuricemia, increased level of uric acid within the blood, and can lead to gout. Ethambutol is the fourth class. Ethambutol exerts bacteriostatic action by inhibiting the arabinosyl transferase enzyme, which is important for the synthesis of arabinogalactane cell wall. So it's also a cell wall synthesis inhibitor. It is given orally. It is generally well tolerated but may cause dose-dependent reversible disturbances of vision. So it can cause some retinitis, and due to which it can disturb the vision, and the people cannot distinguish between the red and green. So it causes a kind of color blindness. The second line drug. So remember, we have discussed if if the patient evolve resistance to any of these first line drug, then we can go for this second line therapy. But you know that it is less effective and more toxic than the first line drug. So there are 6 classes of second line drugs used for the treatment of tuberculosis. Okay, so a drug may be classified as second line instead of first line, or for the two possible reasons. It may be less effective than the first line drug, or their toxicity are more serious. So these are aminoglycoside, polypeptides, fluoroquinolones, macrolides. These are the different types of antibiotics which can be used as the second line therapy for anti-tubercular drugs. These are only used when there is a resistance to the first line drug. Now resistance, it could be multi-drug resistant tuberculosis or extensive drug resistant tuberculosis. So what happens in multi-drug resistant tuberculosis is that resistance is produced to two most effective first-line drugs like rifampicins and isoniazid. So if the patient evolves, or if the mycobacterium evolves resistant to these first two-line drugs, then this type of tuberculosis is called by multi-drug resistant tuberculosis. In some cases, the resistance is spread to 3 or more of the 6 classes of the second line of drugs. So then it is called the extensively drug resistant tuberculosis. Availability of vaccine for this, we have some countries have these bacillus calmette-guerin vaccine, or it's called BCG vaccine, as part of their TB control program, especially for infants. But the problem is that they are effective in the infants but not in the adult population. So according to the WHO, this is the most often used vaccine worldwide, with 85% of the infant in 172 countries immunized in 1993. BCG provides protection against severe forms of pediatric tuberculosis, but unreliable against the adult pulmonary tuberculosis. So that's the problem with this vaccine, that they are effective only in the pediatric tuberculosis in the childhood. Currently, there are more cases of tuberculosis on the planet than at any other time in the history. So there are more and still increasing. So urgent need for the newer, more effective vaccines that would prevent all forms of tuberculosis, including drug-resistant strains in all age group and among peoples of HIV. It's the need of the hour nowadays. So this is all about the anti-tubercular drugs. We have discussed the first line drug and the second line of drugs for the treatment of tuberculosis. The first class include isoniazid, rifampicin, pyrazinamide, ethambutol. If the patient, so these are the more effective and less toxic drugs in treating the tuberculosis. But if the patient evolves resistance to any of these agents, then they can go for this second line of drugs, which include fluoroquinolones, amikacins, ethambutols, all these drugs. So that's all for today. Thank you so much.